Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alamin. So, this is the screencast for parathyroid gland pathology. This is the screencast for parathyroid gland pathology, and we are expecting certain things you guys to do after this lecture. As usual, this is called intended learning outcomes, and what we expect you guys to tell us after this lecture is list the causes of hyper and hypoparathyroidism and its effect on calcium and phosphate homeostasis, and explain the pathogenesis of primary hyperparathyroidism and its effect on other organs, and explain the pathogenesis of secondary hyperparathyroidism such as chronic renal failure and its long-term effect on bones, and describe the morphology of the parathyroid hormone effect on bones, and compare and analyze very important clinical features, serum electrolytes, vitamin D and parathyroid hormone, calcitonin level, and arrive at diagnosis. It's really crucial one, critical one, and inshallah you guys can do this. So parathyroid gland, let us, as usual, our style starts from the basics. So 4 parathyroid glands are located just at the back of thyroid. Remember, when they are removing the thyroid, they should not remove the posterior capsule. So that's why we call the removal of thyroid is called subtotal thyroidectomy. Thyroidectomy means removal of thyroid. Subtotal means they are not removing the posterior capsule. So why? Because if they remove the posterior capsule, then they can remove the parathyroid gland. That results in serious medico-legal case, because they are creating unnecessary, unavoidable hypoparathyroid state. So keep that in your mind. And they composed of chief cells which secrete parathyroid hormone, and they contain secretory granules, all those stuffs, and oxyphil cells and other types of oxyphil cells are called translational oxyphil cells. They are found throughout the parathyroid gland in single or clusters, just they are supporting cells. And remember, when the age increases, the fat increases in the parathyroid gland. That's what I mentioned here. Okay, this is the microscopic picture of parathyroid gland. It is taken from the protein atlas, and it's, you can see the fat distribution and the cells, the parathyroid gland, chief cells and oxyphilic cells distribution is more or less equal. So when you see the parathyroid gland microscopy in higher magnification, these are the chief cells, well crisp round cells, and having a very little bit granular cytoplasm, and these are the oxyphilic cells. Okay, it's like transitional oxyphilic cells. So these are the two types of cells. But actually, if you guys remember, as undergraduate level, this cell which secrete parathyroid hormone. Okay, so these cells are like chemical sensors. Okay, because these cells not actually directly under the control of pituitary, but actually they are under the control of electrolytes, which means if there is increase or decrease in calcium, can make this cell to go for synthesis of this and produce the hormone, parathyroid hormone, or decrease the production of the hormone. So that we will discuss in detail. So now coming to the function of parathyroid gland, let me take the screen and explain. See, parathyroid gland secrete parathyroid hormone, right? Consider this is the parathyroid gland, or we will draw the parathyroid gland inside the thyroid. This is at the back of the thyroid, and we have 4 parathyroid gland. They secrete the parathyroid hormone, and what makes them to secrete, that is called positive feedback. Okay, so if there is decreased calcium, increased phosphate, or if there is decreased vitamin D, these are the things stimulate the parathyroid gland to synthesize and produce parathyroid hormone into the circulation. Okay, so now exact opposite make them to shut down. One is increased calcium, decreased phosphate, or whether there is increased vitamin D. Okay, so now let's discuss whether there is a decreased calcium or increased phosphate or decreased vitamin will produce positive feedback on the parathyroid hormone to produce the parathyroid hormone. So first we'll take the calcium. So what they does with the calcium is, the calcium is decreased, immediately the parathyroid hormone is secreted into the circulation. Once it is secreted into the circulation, it goes to the three organs. Okay, so the first organ what they go and do is they go to the intestine and they increase the absorption of calcium if they have good diet. Understand? They increase the absorption of calcium, and this is the circulation, and then they put the calcium in the circulation. Understand? So slowly they are increasing the calcium in the circulation. So another thing they go is, the second organ they go is kidney. In the kidney they do two things. One is they go and increase the alpha hydroxylase enzyme, and they make the 1-alpha hydroxylase enzyme, they make the vitamin D2 to vitamin D3. They convert the vitamin D2 to vitamin D3, and then they go to the renal tubules. So they go to the parathyroid hormone goes to the kidney, and they converts the vitamin D2 to vitamin D3 by increasing the synthesis of hydroxylase enzyme, and they also go to the renal tubules and they absorb calcium into the reabsorb calcium into the circulation, and they excrete phosphate. They excrete phosphate in the urine. Understand? So this is another function they do in the renal tubules. So now net effect is the calcium is coming back. So once they absorb from the intestines, and then they reabsorb from the renal tubules, and they make more vitamin D3. Why they make more vitamin D3 is, the vitamin D3, okay, they again go to the renal tubules. I'll draw a different color. So the vitamin D3, they go to the renal tubule and they absorb calcium. They go to the renal tubules are not there. So let's draw the renal tubule. Let's go to the renal tubule. They go to the renal tubule, vitamin D3, and they absorb the calcium, and they also reabsorb the phosphate. That's how the phosphate is balanced. Understand? So what is the net effect because of parathyroid hormone on the kidney? So they do two things. One is they increase the hydroxylase enzyme, they form the vitamin D3. They form the vitamin D3. And what this vitamin D3 does, they in the circulation they increase the calcium and phosphate. Then the parathyroid hormone goes to the goes to the renal tubules. They increase the calcium resorption, reabsorption, but they decrease the phosphate and they increase the phosphate excretion actually. So these two things you should know. Then the third organ is the bone. So they go to the bone. In the bone we have two types of cells. There are four types of cells. Now you concentrate on two types of cells, osteoclast and the osteoblast. So osteoblasts are the bone forming cells, osteoclasts are the bone removing cells, and they remove the calcium. 99% of the calcium is stored in the bone. So now the parathyroid hormone goes to the osteoclast and they make the osteoclast to secrete a special receptor kind of thing called rank ligand. So this is called rank L. Okay, rank means receptor activator of nuclear factor kappa. Okay, so and rank L means ligand. Okay, so they have a ligand that is produced because of the stimulation of parathyroid hormone, and there is a rank. So this rank ligand and rank is joined together, then osteoclastic activity is increased, which means bone removes the osteoclast removes the calcium from the bone and the calcium comes to the circulation. So normally it is not occur because it is prevented by a the special chemical substance called, they block this, that is called osteoprotogerin. So this is very important one. What happens is parathyroid hormone reduces this and increases the rank L and rank complex. So automatically the osteoclastic activity is increased. Understand? So another substance does the same effect is vitamin D3. Another hormone like protein which is released by the cancer cells, so that is called parathyroid hormone related protein, that also does the same thing. Understand? So this you should keep in your mind. So what happens is they increase the osteoclastic activity, they decrease the osteoprotogerin. So little bit we'll discuss more about these tumors. Okay, so I will erase or link on the slide. Let's go to the screen again. Okay, let us summarize these things. Because so now there is decreased calcium. What will happen? That will stimulate the parathyroid gland to secrete parathyroid hormone. This parathyroid hormone goes to the intestines and they reabsorb the calcium. They absorb the calcium and they go to the kidney and in the kidney they convert D2 to D3 because of synthesis, make them to synthesize the hydroxylase enzyme. This is one thing they do. Another thing they do is they go to the renal tubules. And they take the calcium, that is they reabsorb the calcium and they send the phosphate out. Okay, so what you have to understand here is these two functions they do. So now the D3 level is increased because of the parathyroid hormone, and this D3 again go to the renal tubules and they reabsorb. This is vitamin D3. They again go to the tubules, they reabsorb calcium and they also reabsorb phosphate. Understand? So that's why the phosphate is balanced. And then parathyroid hormone goes to the bone. Okay, they go to the bone. In the bone we have osteoclast cell and we have osteoblast cell. The parathyroid hormone stimulate the osteoclast cell to produce rankel, and there is a rank. So what happens is this rank and rankel gets combined, then the osteoclastic activity is increased, and the parathyroid hormone also decrease OPG level, because OPG is the one which blocks this rank and rankel. If this is increased, then rankel and rank will combine, they join and they produce more osteoclastic activity. So what do you mean by osteoclastic activity? Osteoclastic activity is the activity by the osteoclast cells. They just destroy the bone and they take calcium from the bone. So they increase the calcium in the circulation. Allahu Akbar, Allahu Akbar. Okay, they increase the calcium in the circulation, and now the calcium level is going up. Then the calcium becomes normal, then the parathyroid hormone is stopped. So this is what happens in the calcium homeostasis and phosphate homeostasis. So let's discuss some conditions, then you will understand. So now let us take there is a parathyroid gland. It is going for hyperplasia, or there is a tumor in the parathyroid gland. So they are releasing more parathyroid hormone. What will happen? They produce more vitamin D3, right? And they increase the calcium level and they decrease the phosphate level. Understand? And now the parathyroid hormone is going to the bone. The bone, they increase the osteoclastic activity. So they make the bone porous, osteoporous. If it is more severe, they produce full of cavity, cyst in the bone. That is because of more bone destruction. That is called osteotis fibrosa cystica. This is called hyperthyroid bone disease. Okay, so now we understand this. So this will be the scenario of tumor in the parathyroid gland producing increased parathyroid hormone. This is one condition. So another condition is, let us discuss another condition. The person is having a lung cancer, and this lung cancer is like a small cell carcinoma, and they release lot of hormone like protein. One of the protein is parathyroid hormone related protein. They work like a parathyroid hormone, but they go to the bone and they increase the osteoclastic activity, and they produce severe bone pain, and as well as they produce bone fractures, pathological bone fractures, because the bone becomes weak. So this is the one seen in the another condition, which is the lung tumor producing the ectopic hormone or hormone related protein. So another condition, we take there is a tumor in the bone coming from the thyroid gland. For example, thyroid gland having a cancer that is going to the bone, metastasis to the bone. Okay, now it is metastasizing to the bone. Always the metastasis will be multiple deposits. Okay, when there are multiple deposits, the tumor is growing. There are some rank is present in the bone substance. When the tumor is growing, this rank is released. The rank substance is released, and that will increase the osteoclastic activity. So we get more calcium because of metastatic bone tumor. There is bone calcium, hypercalcemia, but that will produce negative feedback on the parathyroid gland. The parathyroid hormone is reduced. In this condition, there will be increased calcium, increased phosphate, and decreased parathyroid hormone, and decreased D3. So these are the things you should consider. It is a secondary, it is a hypercalcemia without hyperparathyroidism, because the problem is metastatic bone tumor that is releasing the rank, and that is increasing the osteoclastic activity, that is causing increased calcium, increased phosphate, and because the phosphate is not able to get excreted out because of there is no parathyroid hormone. The parathyroid hormone is less because of the negative feedback because of the hypercalcemia. So this is the condition which results in hypercalcemia, decreased parathyroid hormone. Let us discuss another case. So again we will take a bone tumor which comes as a marrow tumor, which is called multiple myeloma. This multiple myeloma secrete lot of growth factors. This growth factor stimulates the osteoclast cell, increase the osteoclastic activity. So automatically more calcium is coming, that will produce negative feedback on the parathyroid gland, negative feedback. Then automatically the parathyroid hormone will be reduced. Then automatically the phosphate level will be increased. Then what happened, there will be decreased vitamin D3. So it is some other tumor in the bone increasing the osteoclastic activity, producing hypercalcemia. That hypercalcemia is producing a negative feedback and reducing the parathyroid hormone. That results in increased phosphate, because parathyroid hormone is needed to send the phosphate out. Now the phosphate level is increased, and we need parathyroid hormone to make D3. Now vitamin D3 is decreased. This is another scenario. So we will discuss one more scenario. So we all know that in diabetic patient or any disease affecting the kidney, in the long run they go for complete renal failure. That is called chronic renal failure, chronic renal insufficiency. What happens in chronic renal insufficiency? The GFR is reduced, glomerular filtration rate is reduced, so automatically they will increase the serum creatinine, urea, and also what happens is they cannot send the electrolytes down, so their phosphate cannot be excreted. The phosphate level is increased. So the phosphate level is increased. in chronic renal failure. This is the primary problem that leads to as a positive feedback to the parathyroid gland, and that will stimulate the parathyroid gland to produce more parathyroid hormone, because they want to send the phosphate out. So even the more parathyroid hormone comes, they cannot send the phosphate out because the kidney is not functioning. Then this all goes to the bone. And they produce serious bone cystic diseases, that is they call brown tumor or osteitis fibrosa cystica, and this is called renal osteodystrophy. Okay, so this is a serious problem, comes in the chronic renal insufficiency patient. There is increased phosphate, increased parathyroid hormone, increased calcium, and there is decreased vitamin D3, because vitamin D3 cannot be produced because the kidney is not there, they cannot produce the hydroxylase enzyme. So this will be the profile in the chronic renal insufficiency. So let us go to the slide now. So function of parathyroid gland is actually the parathyroid gland is controlled by the level of free calcium in the bloodstream, and remember, decreased level of free calcium stimulate the synthesis of parathyroid hormone and secrete the parathyroid hormone. And another thing is increased phosphate and decrease vitamin D3. So what it does is increase the renal, that also this increased phosphate and decreased vitamin D3 also produce stimulatory effect on the positive feedback on the parathyroid gland to produce parathyroid hormone. So increase the renal tubular absorption. What it does is parathyroid hormone, they increase the renal tubular absorption of calcium, so thereby producing more ferric calcium, increase the conversion of vitamin D to active form of dihydroxyvitamin D3 in the kidney because of increasing the hydroxylase, and increase the urine phosphate excretion by that lowers the serum phosphate level, and they also accelerate the intestinal absorption of calcium. So the net result is increase in the level of free calcium, which in turn produce a negative feedback on parathyroid secretion. So now coming to the hypercalcemia. Hypercalcemia is caused by elevated parathyroid hormone or malignancy such as lung, breast and head and neck and renal cancer and multiple myeloma. So malignancy is the most commonest cause for symptomatic hypercalcemia, and primary hyperthyroidism is more common for asymptomatic elevated blood calciumia. Okay, so hypercalcemia, because malignancy, why it produce symptomatic hypercalcemia is because symptomatic means bone pains, bone diseases, and that is a primary symptom we get in malignancy, because the malignancy directly goes to the affects the bone, that increases the calcium level, then the parathyroid hormone gets involved. That is what is it is involved, it is decrease the parathyroid hormone. So that's why they are more symptomatic in malignancy. So now coming to the hypercalcemia of malignancy is due to increased bone resorption, and it is mostly due to the parathyroid hormone related protein, which increases the osteoclastic activity. So these are the different mechanisms which I explained in the screen, and you can read it, and inshallah we will discuss more in the MSK module also. So now coming to the these two categories of disease, very important. The hyperparathyroidism means hyperparathyroidism, there is increased parathyroid hormone, that is also increases the calcium level, understand. So that also decreases the phosphate level, that also increases the vitamin D3. So what it does, they increase calcium, decrease phosphate and increase D3. Keep that in your mind. So if it is primarily disease happening in the parathyroid gland, it could be of adenoma of any cause, and hyperplasia or parathyroid carcinoma, that is causing increased calcium, decreased phosphate, increased vitamin D3, then it is a case of primary hyperthyroidism. Okay, now coming to the chronic renal insufficiency. In chronic renal insufficiency, there is no kidney to excrete the phosphate level. So now the phosphate level is, the primary problem is the phosphate level is increased. So increase in phosphate level will stimulate the parathyroid gland to produce parathyroid hormone, increase the parathyroid hormone, and increase in parathyroid hormone will cannot increase the vitamin D3 because there is kidney is damaged. So there is only increase in calcium but decrease in D3. So increase phosphate level, that is hyperphosphatemia, causes increase parathyroidism, hyperparathyroidism, that leads to increase calcium but decrease vitamin D3. So this is secondary hyperparathyroidism due to chronic renal insufficiency. So tertiary is autonomous parathyroid activity, which is seen very rare. There will be no morphological disease, but only the parathyroid activity is more. So now coming to the hypercalcemia. You all know hypercalcemia can happen when there is increased parathyroid hormone, whether it could be of any of this reason. But hypercalcemia still can happen because when there is severe hypercalcemia, that can produce negative feedback and stop the parathyroid hormone, so decrease the parathyroid hormone level. So what are those conditions? Any malignancies, vitamin D toxicity, thiazide diuretics, and granulomatous inflammation. Okay, so these are the things can increase the calcium level. Because of increased calcium level, that will produce negative feedback on the parathyroid gland, that decrease the parathyroid hormone. So when there is decreased parathyroid hormone, there will be increased phosphate, and there will be increased phosphate, there will be decreased D3. Understand? Because D3 need hydroxylase enzyme that has to be formed after stimulation of parathyroid hormone. So now coming to the clinical feature of hyperparathyroidism, they affect the bone because they increase the osteoclastic activity and they produce osteoporosis or osteoitis fibrosa cystica, and they also produce nephrolithiasis, renal stones, and remember they also produce constipations, nausea, peptic ulcer, pancreatitis, gallstones, and they produce seizures and depressions, and they make lethargic. Actually they deactivate the central nervous system, and they produce metastatic calcification. So the calcium level is more, the calcium deposits in the normal tissue, that is called metastatic calcification. So the calcium deposits in the valve, heart, lung, blood vessels, gastric mucosa, because they are the alkaline medium. So the calcium easily goes and deposits. So that will produce the cardiac diseases. So please keep that in your mind. That is the clinical features of hyperparathyroidism. Now coming to the hypoparathyroidism, which means decrease in the parathyroid hormone. And remember, it could be a surgery, autoimmune disorders, or hereditary disorders. They produce severe tetany and emotional instability, and they end up with psychosis, hallucination, confusion states, and they produce Parkinsonian like movement and papillary edema in the eyes, and they produce ocular diseases because the calcification happens in the lens and cataract formation happens, and cardiovascular manifestations, they produce severe conduction defects, they produce heart blocks and dental abnormalities. These are the things seen in the hypoparathyroidism. Understand? So remember, hypoparathyroidism leads to hyperphosphatemia, and see, hypophosphatemia happens when there is severe form of vitamin D deficiency. Okay, so because vitamin D is the one which reabsorbs the calcium. Understand? So if there is no vitamin D3, again hypothyroidism causes decreased vitamin D3, but however it causes vitamin D3 to get decreased because of hydroxylase enzymes, and this is But if there is severe form of vitamin D3 like deficiencies, intake nutrition deficiencies, then it will produce severe hypophosphatemia. Understand? So so severe hypophosphatemia, what will happen? That will lead to severe hypophosphatemia seen in the vitamin D deficiency like rickets. So let me go to the screen. Let us summarize the things. See, when there is increased parathyroid hormone and the kidney is normal, so the parathyroid hormone is coming due to decreased calcium. Okay, what happens? They increase the calcium, they increase the vitamin D3, they decrease the phosphate. Understand? Because they allow them to excrete it. So hypophosphatemia can result in increased parathyroid hormone. Understand? So but it can be counterbalanced by vitamin D3 because it can reabsorb it. But moreover, actually clinically our electrolyte level, they reflect there will be decreased or low average phosphate. Okay, and actually this, frankly speaking, I am explaining this whole phosphatemia, hyperphosphatemia, because of a student asked a doubt. I hope inshallah this video will help her. So vitamin D3 is a primary deficiency, like in the rickets, they directly cause hypophosphatemia. Understand? When there is severe hypophosphatemia, that also serious problem encountered in the vitamin D3 deficiencies. Understand? But this hypophosphatemia caused due to the hyperparathyroidism, due to the decreased calcium. This is the normal hemostasis. Please try to understand this. So here this will not produce serious kind of hypophosphatemia. But if the tumor is producing too much of hyperparathyroidism, then the hemostasis is get altered. Okay, so I hope this doesn't confuse you guys. Okay, actually this is meant only for that student who asked doubt about hypophosphatemia, and still she is not understanding, and inshallah she can ask me again in the email. So this ends the screencast for parathyroid gland pathology, and once again I am emphasizing the best learning resource is the Robbins textbook of pathology, and if alternative is Pathoma, and but we strongly suggest to read Robbins. Masalama.